Welcome to JAMA Plus AI Conversations. I'm Roy Perlis, Editor-in-Chief of JAMA Plus AI, and today I'm joined by Associate Editor Yulin Hswen. We're planning to talk today about some of the most cited papers in the JAMA Network in AI over the past year. But first, I want to mention a very interesting one called Building from Experience with Predictive AI, Rapid Uptake of Generative AI Among U.S. Hospitals by Everson and colleagues, published in JAMA Network Open recently. And the reason to start there is I think it's really remarkable how quickly Gen AI is diffusing across health systems, with about 1/3 saying they're already using AI integrated into their health record, and another quarter planning implementation in the next year.
Yeah, what stood out to me about this paper was that the adoption of it wasn't evenly distributed. I mean, it makes sense. And the system affiliated hospitals and Epic sites were more likely to be early adopters. But what I'm thinking is that many of these hospitals are adopting generative AI, but have not really evaluated their predictive AI models across key domains like accuracy and bias and just deployment monitoring. And, we talk about it all the time where we are not seeing these type of forward studies, right? These prospective studies that we want to see. And yet we're seeing hospitals adopt them. So does this kind of suggest that we're scaling tools before adequate guardrails are being put into place?
Yeah, I think it also means that those who move first may not be making the most informed decisions. There's a nice commentary that goes along with it called Generative AI in Healthcare is Faster, Better, that I think makes this point. It really argues that the early adopters may be underestimating the risks because, frankly, they're not looking for the risks. They're tending to do minimal evaluation. And we don't want to generalize. I mean, it's not necessarily the case everywhere. But it is true that organizations that are taking time to do more assessment, more measurement of things like accuracy and bias in their own systems probably are going to be slower to adopt Gen AI in clinical settings. So we have this tension between speed and safety, right? There's like move quickly, or there's figure out how safe it is and maybe move quickly later. And I think we're seeing some balance between the two at this point.
And also, the commentary also raises this important issue of the fact that this concentration of AI innovations is among few vendors, right? So when Epic or other major vendors release generative AI features, it then shapes the market. Like, are people then going to follow that type of model kind of immediately because hospitals are putting those forward? And so you have smaller companies that also may hold back, even though they might have different approaches or more specialized approaches. And so it kind of creates that type of dynamic effect of who benefits from generative AI and who might be left behind, or what type of tools are kind of left behind in that process.
I agree with you, and I think Epic as the 800-pound gorilla is really shaping the field in many ways because they can perhaps sit back and say, "Oh, that's a nice feature. Yeah, we'll do that too." And it may be on some level a little bit of a barrier to innovation if smaller companies feel like they can't take that risk of just being pulled into the Epic ecosystem. I guess to be continued. We'll see how adoption. I think we've seen the early adopters. I think this coming year we'll see how this plays out on a larger scale. I want to shift gears a little bit and talk about the articles across the JAMA Network in AI that were most cited over the past year. And, I should say, we know that citations are not a great measurement and, all of the usual caveats. On the other hand, it does tell us something about how much attention some of these papers are getting. And I think often for good reason. So, Yulin, why don't we go through some of them?
Oh, absolutely. Happy to. So, one of the most cited articles this year was Physician and Large Language Model Generated Hospital Discharge Summaries by Williams and colleagues in JAMA Internal Medicine. And I think why this study was probably very popular is because it compared 100 hospital discharge summaries written by physicians with versions drafted by a large language model. And this is the year of large language models. And we're all looking to understand if they are going to be integrated into hospital systems, right? And so what the study did is they had blinded reviewers and they found no significant difference in overall quality or preference between the two. So we kind of keep on seeing that theme. They found that the LL summaries were more concise and coherent, but the caveat was they were less comprehensive and contained more errors, but the errors were mostly low harm. And so, really, I think one of the things of this no harm is that both the large language models and physician summaries scored very low on potential harmfulness, with only one LM note reaching a level of associated with possible permanent harm. And so overall, we're seeing more and more that the hospital systems are potentially going to adopt this type of large language models because of the fact that they may not differ so much. But again, we've talked about this in other podcasts, but I do worry of this idea that are we going to lose that aspect as you talk about where you have clinicians who are taking the time to generate these summaries and generate that type of reflective period. Is that part of the clinical care that we're going to miss? But again, I do think it's a very popular article for the reason that this is the year of LLMs.
Well, as someone who remembers sitting with, giant stacks of charts for people who've had long hospital admissions and trying to condense it down to a discharge summary, I guess I appreciate the possibility of automating this. On the other hand, I wonder if one of the reasons there was no difference in overall quality may be more about the quality of the clinician-authored discharge summaries than the language model-authored ones. It's really hard to condense a long hospital stay down to a readable discharge summary. And yeah, we may end up with language models reading notes written by language models just to get them to a level that a human can actually interpret. But I'd say it's encouraging. The one that I wanted to mention was from JAMA Psychiatry. It was Hansen and colleagues, predicting diagnostic progression to schizophrenia or bipolar via machine learning. So bonus points for actually calling it machine learning, not artificial intelligence. Um, so what they did was apply routine health records data from more than 24,000 patients as a means of identifying who is at greater risk for developing schizophrenia or bipolar. One of the things we should stress is it's not that these patients were sort of asymptomatic and the health record said, oh, no, they're going to go on and have a major psychiatric diagnosis. These are people who were already in the mental health system, right? So they were already in contact with care, but some aspect of the records indicated that they might be higher risk. And I think that's what accounted for the fact that they were able to get an AUC of approaching 0.8 for schizophrenia versus only 0.62 for bipolar disorder. Now, I'm not a fan of AUCs. Obviously, there's no magic to those numbers. But still, no, it's pretty encouraging and suggests that we may get to the point, we are not there yet, but we may get to the point where we can start to stratify risk earlier in someone's course and say, this is someone who might need a higher intensity of follow-up, for example. So I thought that was interesting, and I wasn't surprised that that paper got a lot of attention this year.
I also think it's what I appreciate about the study too is that it focuses on using data that already exists in routine psychiatric care. I think so much of the time, in my field, we want to add more work, we want to add more data collection. And so if we can start building models that is using data that we routinely collect, I think is really beneficial. And you're the expert, but we know that delays in diagnosing schizophrenia can be long term. And so is it the case that even a moderately performing model could help clinicians flag trajectories earlier?
Yeah, and I just have to add to this that one of the things we have to stop doing, at least in psychiatry, but I think in medicine in general, is publishing these, encouraging prediction models that then don't go anywhere. So my hope with this one is that someone follows it up and says, well, that's a cool model. Here's how it performs in this other health system, because that's sort of a necessary step on the predictive AI side. not the Gen AI side, but on the predictive AI side to actually getting to deployment.
Mhm. So, one viewpoint that got a lot of attention that I noticed was moving towards implementation of responsible artificial intelligence in healthcare by Ben Gendron in JAMA. And what I found interesting about it as well is that it talks about the European Train Initiative, which is essentially Europe's answer to responsible AI governance. And I think it's really great that JAMA publishes, globally about AI governance, because sometimes I think that we need to look to what other countries are doing, and they need to look to us to see. Again, I mean, it might not be perfectly scientific, but it is this natural type of experiment where we can learn. And so with EU's new AI Act treating medical AI as high risk, Train Europe is trying to give hospitals basically a practical roadmap and keep inventory of every model in use and test algorithms on local data before and after deployment. And so it's basically measuring how widely AI is being used at the bedside. And what is nice about the articles is it talks about that it's not just about regulation, but it's really this attempt to democratize responsible AI. So even smaller hospitals can meet these standards, right? And what it's also trying to do is trying to connect this work to US train network to align global best practices. And so, again, in summary, it's just an overall reminder that AI adoption is not just a technical challenge, but a coordinated governance effort. And so it's trying to work together kind of globally to better understand AI and, how to manage this genie that's come out of the box or lamp, I should say. Sorry.
Yeah, I think Pandora is the box and the genie.
Yes, thank you.
Um, but, it's an interesting contrast to the US, right, where we're still arguing about how we're going to regulate AI in the first place, and not just health AI, but AI more generally. So, at least in this domain, I do think the European effort is important to watch, because it may be a model when the US does get its act together for how regulation might look here as well, or at least how responsible adoption may play out.
Yes, it's very different. I feel Europe has been a little bit more forward on the AI governance. They've been very active in having a lot of discussions. And so I think it's nice that we have this to be able to follow along. And so I look forward to articles that hopefully might be able to evaluate this policy, with empirical evidence to see how it pans out and how that either disrupts innovation, encourages it, or, helps, for instance, save lives because of the regulation that they're putting under.
So the next highly cited paper this past year was called Automated Deep Learning Phenotyping of Tricuspid Regurgitation in Echocardiography. It was in JAMA Cardiology. And we've talked a fair bit about Gen AI. We've talked about predictive AI. This is what I would put in the category of multimodal AI, because it's really image processing. And so essentially what they're doing is they're building an automated deep learning pipeline called EchoNet TR to read echoes and grade tricuspid regurgitation. So they used more than 2 million echoes, videos from echoes. They built an end-to-end deep learning pipeline. They find the right apical four-chamber view, then they grade tricuspid regurgitation severity and determine whether it's clinically significant. And what I found appealing about this one is that it really does suggest that you could use AI to do large-scale screening for a lesion that is fairly common, prognostically important, but can often be missed in routine echo. So it is using the capacity of these deep learning methods to parse not language in this case, but actually videos.
So I tend to like these articles. I think I talked about it on some of the articles that I found really fascinating this year. But I think that, using images and video is something that AI can really analyze at a massive scale, right? They use 2 million videos of echocardiography, and that's a challenge for humans. And so if we can start using AI to process those and be able to detect abnormalities that are not always discerned by clinicians or the human eye. I find those studies fascinating. And so my assumption is why this study got a lot of attention as well is because it's cardiology and it's videos. So the last article that we're going to discuss is the research letter in JAMA, and it is a randomized clinical trial. Manual versus AI assisted pre screening for trial eligibility using large language models. And what I like about it and what you will like about it is because it moves AI from theory into the day-to-day mechanics of clinical trials, which is what we do want to see. We want to see these clinical trials and having AI be put into clinical practice and tested in this manner, right? So they used an LLM-based tool to pre-screen patients for a heart failure trial, nearly doubled the rate of eligibility determination and increased actual enrollments while working over the same time budget as staff. And we have to give credit to the study design here. It was a true randomized trial, as I mentioned. And they didn't just show that AI could find patients, they showed it actually doubled the enrollment rate, right? So you had 35 patients versus 19 in the manual arm. And that kind of ROI that hospital administrators they listen to, right? And so if we design these systems carefully, then AI can be able to take on that task of reviewing and getting patients into trials faster and more efficiently.
So I really like that study as well. And I think I like that it's a randomized trial, but I also like that it's moving a little bit beyond the clinical setting and saying we can do more efficient trials if we link these kinds of tools to our health records, right? So it's the second paper that we've looked at that's really saying how potentially useful these tools are in summarizing clinical documentation. One was the discharge summary one is this one.
And, it might not be something that everyone understands or is aware of, that clinical trial enrollment is actually quite difficult to actually screen and be able to find patients that are eligible. And it really is done a lot of the time manually by coordinators who have it checked over by clinicians. And so, this potentially is more upstream in terms of not necessarily creating the diagnostic tool or treatment with AI, but really trying to enroll patients to then be able to, deploy the treatment that isn't necessarily AI or test out a certain diagnostic tool or care regimen that is going to benefit them. So I do find that it actually is a very useful study.
I think, across the papers we started with and these five, really the theme to varying degrees is whether or not they're ready for prime time. Everyone is now thinking about deployment and how will we deploy these things? How will we do it safely in a way that, maybe in past years it was proof of concept. Now it's very much moving towards what is the evidence that this is ready or not ready to start moving to the clinic, or in the case of the last paper, to clinical research.
Exactly. And we keep seeing this across the JAMA network. The studies that are gaining attention are the ones that combine the scale and clinical relevance and immediate decision making value, or are the ones that our audience and readers and authors are very interested about. So take note of that, audience. And so it kind of points to the future where AI can be predictive and can play a central role in healthcare. But that readiness gap is real. And so we have these models. We need to deploy them and test them in the clinical setting and have proper evaluation processes to be able to see if it is biased or it is effective. And so we still ask the question if these systems can adopt quickly and also responsibly.
So, as we get that kind of real world evidence, we hope that we will bring it to you in the JAMA Network and talk about it on JAMA Plus AI Conversations. In the meantime, Yulin, thanks for joining me. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, you can visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. We'll see you next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.